Hello, everyone. This is your host, Susan Rosen, and my guest today is, and I will probably wreck this like I wreck everybody else's names, Tim Bilbrey.
Perfect.
Yeah, good. Okay.
Gold star.
And Tim has a very interesting experience and background, and he's been in inpatient and outpatient cardiac rehab, and he has also worked in hospitals. I believe he started in hospitals, right? Working.
Yes, ma'am.
And then after doing that for 15 years, he decided that there was something that he wanted to bring to the world and opened up a company called the Recovery Plus. And he's going to tell us all about that. And, and particularly, I think it's important for everybody, but I think it's also particularly important for people who are over 50, because we're the ones that start to have a lot of these issues. We were healthy beforehand, and then all of a sudden you hit that 50 to 60 age and things start to go downhill, So we all, I think, at some point in our lives may end up needing some sort of help like Tim is providing. So Tim, why don't you can add what you want to after I massacred that whole
oh no,
that
you did a great job. Thank you very much, and thank you for having me on the podcast. And yeah, my name's Tim Bilbrey. I'm an exercise physiologist. I've been in what we would call traditional cardiac rehab, hospital-based cardiac rehab outpatient programs for about 15 years. In about 2018, I started a company called Next Gen RPM, which eventually turned into Recovery Plus USA. RecoveryPlus.health is our website. And we started basically looking at the components of traditional outpatient cardiac rehab. Historically, there's always been a very low participation rates because it's usually from geography. There's not very many of these cardiac rehab programs out there. And then two, looking at as far as where these programs exist. And then myself, I'm from a rural part of Texas, but I get, again, like over those 15 years of cardiac rehab, I lived in the Dallas-Fort Worth area. But growing up in the rural part of Texas where you see cowboys and horses and everything else, we're one of those where we'd have to drive to the hospital, drive to the doctor. It's a half-day event. And there's no cardiac rehab programs out where I currently live, and it's a very large area of the state. And over the course of about 500 square miles and a few 100,000 patients that live in the area, there's one cardiac rehab program, and it's about over an hour. So recovering from a cardiovascular event or cardiac surgery, heart attack, bypass, stents, heart failure, there's a very limited access to care. And then we had come in 2018, started the Next Gen RPM and RecoveryPlus.health, and then really started bringing these services that is primarily inside the urban environment, inside the urban hospitals. We regardless of a patient's geographic location, we can actually provide home-based services to them, not home health, but we can provide these home-based therapy services back to the patients inside the home.
Wow. Yeah. No, I can see where that could be really, really important. I mean, I personally, I'm from Los Angeles. I grew up there, moved up to Northern California. So I've always been in a place that's crowded.
Right.
More crowded now, but always had, and had a lot of hospitals and a lot of doctors and all of that kind of stuff. And so I can see where the service that you're providing can really be so life-saving, because I don't know, people really have to be motivated to go to get help.
Right. Well,
right.
and and you're absolutely right. And usually where we see it from our side, especially coming from the actual hospital-based programs, again, I see patients, inpatient and outpatient. I would see them right after they got out of surgery, right after they've had their heart attack. And it was always a real eye-opening experience for myself, especially when I first started my career in cardiac rehab. Is you're in the environment of the patients are in ICU. You're in the environment to where and that's kind of been my exposure whenever I was much younger and in high school. You start trying to figure out what you want to do with your life. Well, grandpa had another heart attack. So, you get the phone, you get that phone call of, hey, you need to come up to the hospital. It's, grandpa or uncle or, had a heart attack. And, everybody, it's that real scary phone call that, everybody goes up there to see, hey, if he's going to make it survive. Fortunately, we had a positive outcome. The doctors and hospitals did a great job, and we're able to save the family members. But that's where you start getting that exposure to cardiac rehab, because they can't drive, their own limitations, and so they need to go to cardiac rehab. So I was the 16-year-old in high school, everybody's working, but I could, I'd get out at a decent time from school and I could take grandpa or, whoever, I could take them to cardiac rehab, and you would take them 3 times a week, and they would do the hour and they would do their exercise sessions. And, that was my first exposure to that. But if there wasn't, and you could see how well the patients were able to respond, right? Living their everyday lives, living their leisure activities, going back to work, there was that piece of, they would go in and you could, they're low on energy, they're experience a, cardiac event.
Yeah.
They would go in the rehab, and then you're just like, it was just, really quick over time. It's just like, they just kind of, it's like their body woke back up, and they had all this energy again. They were able to respond. But I'm just, that was one of those things to me is, if the patient, if my family member didn't get to go to cardiac rehab, what would their recovery would have looked like? Even from my 15 years, that's what I went to college for, exercise physiologist, cardiac rehab, prominent hospitals out of Dallas, Fort Worth. And the national average participation rates for patients post cardiac event to go into an actual cardiac rehab program, the participation rates are 15-20%.
Really?
Yeah. And it's decades long problem for people to be able to go, because there's such a limited number of these facilities. And again, a lot of times you drive, you have to go back to work, that's usually a lot of pressure from them. But then again, it's also patients who would like to go into cardiac rehab, they don't have a program by them. There's a default if then they don't get to participate until now.
Yeah. So tell us a little bit about, how the program works. How is it different than, the in-hospital kind of thing that you were talking about? That's kind of the norm.
Yeah, it is. And if any of the listeners, if they have that ability to be able to, participate in cardiac rehab, it's one of those, especially like if you're able to participate and you notice that there's a facility-based program viewer that you're able to attend, that would always be our number one recommendation is, if you can go to a professional cardiac rehab program, please go, because it's, like I said, it'll help them recover, it'll help their loved ones recover, and it'll help, change their life and get them back into their everyday life. Also noticing if it's the 80%, national average that are unable to attend, then really it's, where this program greatly differs is, for one, we always want to make sure, that we communicate, we can get, alerted from the patient. Patient can always come out and reach out to us through our website, RecoveryPlus.health. They can always send us their information, and we can check to see, if this would be a good fit for them, because we would reach to their doctor, their doctor, cardiologist, primary care, family doctor. We would always want to make sure that, that they're safe and that they're cleared to be able to participate in this program. Also, to understanding that once we receive that referral, then that's kind of where, we will communicate with the patient, talk to them back and forth, and just really kind of see, what is it, what's happening, what's going on, what would you like to get back to doing, understanding more of the whole, total body, total wellness picture of the patient, of really looking at it from a whole standpoint of, it's, you can participate in this program, but let's look at it from the side of, let's really look at it from the standpoint of, what is it that you would like to get out of participating in this, right? Is this getting your health and wellness back into place? Is it being able to return to, what kind of, go back to work, or you like to go back to gardening, or you like to play with your grandkids, we'd like to be able to get up and down off the floor and roll around with them, so we really take that whole picture of what the patient wants to be able to get out of the program, and then we create, we customize and we'll create that plan with based on what they want to do, because it's not just, keep in mind, if the patient's at home, a traditional cardiac rehab, you go and you'll start walking on a treadmill, and then you'll have some dumbbells, and then you'll maybe use one of these, cycling machines, and a recumbent stepper or something like that. But understanding here, if you don't have that equipment at your house, which 99.9% of us don't, we look at what we call functional movement patterns, right? We body weight exercises, strength, flexibility. There's a whole world of things that we can be able to do and train and teach the patient at home. Obviously supervise, we do one-on-one or group sessions, but creating the exercise prescription based on what the patient can do at home, because that's always been one of those things that we've had in a traditional cardiac rehab setting. You have a patient walking on the treadmill, and they become really good at walking on the treadmill, but once they leave your program, they're no longer walking on a treadmill. While we do encourage, patients to be able to walk and go on walks at home and things like that, there's other factors you got to worry about of, what time of the year is it? Is it in Texas? We get really hot and we can get really cold. So there's only a brief window of when you can go outside without having to, sweat through your shirt or anything like that. So we take that into consideration. But also to create that program, that really customizable program, so that the patient can, what is it they want to get out of the, really want to get out of this type of a program.
Yeah. Well, and even with walking, it depends on where they live, right? I mean, if you live in the middle of a city, then you probably have sidewalks all around, and even then you need to be careful. I can attest to that. Because they get off, the ground settles, and they're not level, and but there are a lot of places where there aren't sidewalks all around.
Right.
Right.
And it's really looking at it from creating a safe environment, for patients, because again, you live out in rural Texas like me, you might have very good cell service. And even too, looking outside where I am right now, I have big, mile-long dirt road that leads to my house. So I'm like, you could, it depends, different strokes for different folks, but especially coming after, if it's a cardiac event or anything like that, maximizing safety and making sure that, especially when starting out, you always want to make sure that, the patient's safe at home, they're able to do it. And it's not this really robust and, you're doing, squat jumps at home. Create a program. We understand that we're not, trying to create a weekend warrior and, we're not trying to train for the Olympics or anything like that, but it's, identifying what the patient wants to do and then creating a, safe, exercise prescription for them at home so that they can, again, for example, if someone wants to be able to get up and down off the ground and play with their grandkids, then, teaching them, how to properly, because there's actually, there's, especially if patients are especially if someone has a hard time getting up and down off the ground, there's actually like an unfolding process, to be able to get up and down off the ground. And it's not put your hands down and just stand up. There's different body mechanics that you can use that can help you up and down off the ground, and just knowing, and understanding what the patient has available to them, and then creating that based on what they can do.
Yeah.
What they have access to at home as well.
Yes. Yeah. And people, older people, I think in particular, but probably all ages, tend to grab onto things that they shouldn't to help them get up, like a chair, or something, and they take the back, and then it goes down, and they go down, and they're in worse shape than they were when they started the whole thing. So yeah, households or where people live can be very dangerous places.
Right. No, it really can. It really can, especially eliminating any sort of, trips or falls. Sometimes be very conscious of, a rug. Something so simple as a rug, or the location of a coffee table and how far it sticks out from the couch, or things like that. And so, yeah, I mean, that's one of the things that we're able to do, and we're looking at the like I said, especially like video face to face. Especially being able to understand the lay of the land inside the patient's home and what they have access to. And is it a wood coffee table versus a glass coffee table? And there's things to look at of, again, of what's in that patient's home. And then, making any sort of necessary adjustments from that.
And then do you also get, if they are living with other family members, do you get the family members involved as well and kind of helping them and doing some of this?
Yeah, no, absolutely. That's a great question, because this is one of those that really big differentiator with us, and like your traditional, traditional cardiac rehab program, is we actually have a program that we call prehab. And so it's one of those, to be able to start in traditional, like a cardiac rehab setting, you have to wait for, you have to have the heart attack, and this is for insurance to cover and pay for it. Which so much, is dependent on the insurance's ability to, being able to provide, pay for services and keeping it at a high quality, low cost on the patient, or no cost. Is traditional programs, you would have to get, you have to wait for the heart attack, or the stent, or the open heart surgery, or if heart failure, for example. And it's unfortunate, but if, for example, if a patient has Medicare and patient has heart failure, but there's a number that is closely associated with the diagnosis of heart failure called an ejection fraction, which basically is the amount of blood flow the heart is able to pump, effectively through the actual chambers of the heart and into the body.
Okay.
And so an ejection fraction, if it's 35% or if it's higher than 35%, you're not eligible for cardiac rehab. So basically what that means is, if your ejection fraction is 40, you're getting close, but it's unfortunate. You would have to wait, just like you have to wait for the heart attack or wait for the heart surgery. You have your heart failure to get worse, or you can start a medically supervised exercise program with an exercise physiologist, dietitian, doctor reviewed. And so that's always been the biggest, challenge over, my 15 years inside rehab, is you're just like, you have to wait for the heart attack. And that's highly unfortunate, but that's one of the big components that we had with this program, is the Recovery Plus program, is that, like you said, when you brought up the spouse, or, or the kids or grandkids, or absolutely, we have, again, our prehab program, to where it's insurance, insurance will cover it, but we can do these exercise programs. We build the components just like a traditional cardiac rehab, to where you really, on face value, you're not going to notice a difference, because we still provide those same services. But we just kind of, we have our, the the doctor reviews it. You know, it's all a little different on the back end on how the doctor reviews it, the care plan that's created, and that we are very attuned and astute to being able to do. So we do have, you know, spouses, patients and their spouses, husbands, wives, you know, partners. We have, you know, kids or grandkids. We even have a parent and their child who is in their 20s, and they'll actually be able to participate. They're both eligible based on their medical conditions, their medical history.
Oh, wow.
They're able to do the program together, and they will, and it's, you know, you have your compliance buddy that to where you have, you know, you have that accountability partner that's your neighbor, your spouse, your, you know, your child, your sibling. And so, you know, if you're, you know, to be eligible for the program, you just have to have 2 chronic conditions, you know, which could be anything from or obese or diabetic, or, you know, you have hypertension, prehypertension, high cholesterol, you know, vascular disease, lung disease, post-COVID, COVID recovery. I mean, so there's a whole, you know, there's a whole list of diagnoses, and you just need to have 2, and insurance, you know, the insurance covers the prehab components of this program. And so, yeah, it's, we've in some cases, we've made it a family affair, and, but it, like I said, it's one of those, you know, you don't have to wait for the heart attack to get the exercise therapy and access to a dietitian and a nurse. And
it's preventive.
Yeah. It's what's called a primary prevention model. And that's one of those that, it's, you know, that is a program that we've been able to offer and roll out to, you know, people in the community to, you know, help them not get worse over time, so that they, you know, again, avoid the heart attack if possible. Let's avoid, you know, any sort of advanced, you know, COPD or, you know, any advancement in asthma or vascular disease or anything like that. Or even if it's general weight management, if a patient would like to lose, you know, 20, 30 pounds, you know, and we've even been able to enroll patients in there just to kind of help, you know, again, that's where it kind of comes in. You find what the patients are here for and what they want and what they want to do. And then we build the program around them.
Interesting. So does it cover also things like osteoporosis and osteopenia and that sort of thing?
Yes, ma'am. There's, and in the weeds of it, there is, depending on whatever kind of condition you have, we do have some patients with chronic pain. We do have some patients with, like you said, osteoporosis, maybe depression and anxiety. And it's, you know, based on what, you know, every one of those, the Medicare has created a number, what's called an ICD-10, which is basically a diagnosis code. Instead of saying, you know, heart failure, it's, you know, systolic heart failure, it's a, you know, it's an 72.212, you know, that's, you know, these you know, these numbers. And like I said, as long as you have 2, then it's, you know, is it osteoporosis in the knees? Is it left knee, right knee, bilateral? And so we, like I said, that's where we come up with the, you know, talking with the patient, talking with the care physician, referring provider, cardiologist, specialist, whatever, you know, we'll identify what those chronic conditions are, those diagnosis codes, and that comes in and supports the program. But that's the requirement that the Medicare and commercial insurances will need to be able to cover those programs. But that's something that we would take on our side.
Yeah. No, because that's the reason I ask is just because everybody thinks, you know, that after you have some sort of chronic episode, right, whether a heart attack or, you know, something major, that, oh yeah, then you get all this therapy and whatever you want to call it. But there are so many things that are just things that people have to live with.
Yeah.
You know, like osteoporosis, that can be just as difficult and painful as all these other things. And there are things that you can do if you're willing to do it. And you're kind of a program, you know, sounds like it's something that would get people on board, you know, to really do it.
Yeah, and you make a very valid point, because I mean, especially with I'll use the the osteoporosis, like for example, let's
Mhm.
say it's in one of the knees or both knees.
Mm.
That over time, as the disease process kind of starts that that downward trend of, like I said, I have family members galore that have had joint replacement and everything else, but I know neck surgery, back surgery, knee surgery,
Mm. Mm.
so I've seen that from a personal perspective, and especially noticing too, it's over time.
Yes.
A person becomes structurally less mobile,
Oh,
right?
yeah.
So when they become less mobile, now you're you're unable to participate in certain your what we call your activities of daily life. You're not
Mhm.
you're not able to walk it as well, if at all. It's
Mhm.
difficult to get up and down out of a chair, and so
Mhm.
I'm more sedentary. Slowly, over time, you
Right.
become based on the physical limitations, you become
Mhm.
sedentary,
Yeah.
and then which is, like I said, it's understanding that, but yet how can you still be able to increase activity for someone who has become
Yeah.
sedentary? And then this is, again, also due on our side, being able to provide feedback to you, is it whether it's the an orthopedic surgeon or your primary
Yeah.
care, having your care team,
Yes.
and having us being able to provide that sort of feedback directly. Is like, they're the pain, a pain scale, 1 out of 10, 10 being the most severe. Well, the patient's now starting to experience more pain, more swelling. Oh, or if they've been put on a good protocol, and they're able to kind of they're feeling better, their pain
Yeah.
is managed, but then they're wanting to go back and start initiate an exercise program, something that they might haven't had to been able to do in a while, but then again also too needs the assistance or help being
Mm.
able to create that, so that one, you put as little impact as possible on the joint in
Right.
question. And so yeah, there's that piece of that, and how we can create that program too, even for that patient, based on that
Mhm.
criteria. And like I said, and I can absolutely say every patient or program is different, and there is a different component for each. So this is where it becomes a highly individualized program based on what does the patient want to get out of this? Is it XYZ 1, 2, 3, and then around that.
Uh-huh. Yeah. Yeah. Oh, no, I can see where that's so important. So you do this online, you do it on Zoom, or you know what or do you have people come in and actually do the first intake, in person? And I think I lost you. You seem to be frozen. Hello. So we have our guest back again. He got thrown off of the internet and now he's back. And so we are going to segue to another area that kind of goes along with what we were already talking about, which I know a lot of people are concerned about, as they should be, which is COVID and and long COVID, and or people who've been in the hospital, although that doesn't, well, I guess it still does happen if you're not vaccinated and all of that. But so anyway, so where do you guys come in on that um, timeline,
Yeah,
I guess?
a lot of what we've seen, again, we started our home-based programs pre-COVID. Again, we started this around late 2017, early 2018, and then once March, April 2020 we came in and we modified our program, because a lot of what we do, when you look at the pillars of, especially with what we do with our program, it's measuring biometrics, which are your vital signs, symptom management, exercise, and diet. And then, being able to create a program, your medication adherence, participation, compliance, things like that. So one of the things that we saw, especially when the COVID outbreak hit March, April 2020, is being able to come in and we, noticing that, especially when Alpha and Delta were really hitting, looking at it from the standpoint of, what can we do? Because we're already collecting symptoms on patients, shortness of breath, increased shortness of breath. Are you feeling better or worse? Or is it about the same as yesterday? And so, and then you have your, the pulse oximeter, the little finger probe that measures your blood oxygen. So, one of the things that we came in and did is we tilted our cardiac program a little bit on its axis to really try to help focus on the respiratory pulmonary side of it, and monitoring patients who are COVID positive, and then once they're became COVID negative, and the follow up with their primary care physician, being able to create again, it's the term that's being thrown around a lot right now, and it looks like that terminology might stick, is what they call COVID long haulers, to where you're still showing symptoms, decreased energy, maybe a decreased function, weeks and months after you became COVID negative. And so there's some papers out there that early papers that were coming out there, talking about the clinical studies regarding that the patients are showing heart failure, COVID recovery, patients are showing heart failure like symptoms, months after their COVID diagnosis. And so really that's one of those things that, again, when we first got in with this and altered our program, but then seeing the way that the community support, the medical support with a program like ours is, helping patients after the COVID long haulers, if you're experiencing symptoms, weeks, months after, being able to have you in this in a type of program like ours that can actually help document medically, supervise, help people understand what numbers, what biometrics, what heart rate is good, what a good blood pressure is, what and then supervising exercise and help them start an exercise program, understand what their symptoms might look like, and then progress them through, again, days, weeks, months, years. We've had programs. There's not necessarily a time limit on our type of a program, as long as, again, medical justifiable, and that we can actually show, compliance and progress and things like that. So we've even had patients in our program for years, to which, the design is, again, keeping patients, happy, safe, healthy at home. So that we can try to avoid any of these unnecessary ER visits, reduce hospitalizations, help take the strain off of the medical facilities and doctors' offices, especially if something's truly preventable, being able to kind of just again, provide that medical surveillance for patients at home. COVID long haulers, being able to provide them an exercise routine, wellness program for them to be able to go through day by day, week by week, and getting it walked through with them with our clinical team, nurses, doctors, dietitians, exercise physiologists, and creating that program to help support them in understanding, the disease process, or maybe even some of the debilitative effects that they've had after they receive that COVID negative diagnosis.
Yes. Yeah. No, and that really is so important, because like you and I were talking about before we started recording, is that there's so much about this that they just don't know, and it keeps morphing and it keeps changing. And like with so many other diseases, people's reaction or how it affects them can be so different. It's not like, you broke your arm, now we have to set it, now we have to wait for it to heal, right? And then maybe we'll give you some physical therapy.
Right. No, that's precisely it.
Yeah, yeah. So you guys have really been learning as you go. It's kind of an exploration almost in dealing with
Right. And
that as to what works.
and there's things that we're looking at too. Even we're currently working on even drafting a clinical study right now, especially from what we see, from what the patients are at home, exercise, what kind of symptoms and biometrics, because the more that we can learn as as a society, especially providing, that's one of those things that, especially in a clinical study, but also too, numbers don't lie. And so being able to have that and provide that, and if it can help, if we're able to help and shed some light on maybe some, considerations, or from our program, what do we see that's working? What are we seeing that where there's improvement, and maybe there's a communicational piece, or maybe even a treatment protocol somewhere down the road that can help, again, as we go through this all together, and as we learn, being able to create, that more of that, again, that home treatment model of, shedding more light and understanding more about with COVID. And as it mutates, it's probably going to mutate a few more times. And unfortunate, maybe even the new norm. But, that's, as we work through it, then, we'll try to do our part.
Yeah. No, absolutely. I think it's it really is so important, and and you guys have the resources and the experience to work with it, right?
Right.
It may be a different color or something. I mean, but it's different, but it's still the same process you go through to figure it out and to develop a program for somebody.
Right. And especially watching it, how it especially played out, especially with, Alpha and Delta, looking at it as it's played out, and, then going through the process with Omicron, and then, seeing the different, the way that different strains are affecting patients and their ability to participate in, again, their everyday lives, them being able to go back to work, and, having something structured, and here's the body's response to exercise based on XYZ. Here's the, chronic conditions that this patient has also had, and then understanding and knowing, then being able to maybe help other patients or help other providers be able to provide them with that information, so that, again, we can make a better game plan on how to beat this thing.
No, I agree. So it sounds like you're keeping busy with all of this, and I think it sounds really great. I mean, you're doing some really wonderful work.
Thank you very much.
Helping people.
Very much. It's been well received, and we're looking to continue to keep helping patients and helping our community.
Yeah. Oh no, absolutely. And so do you is it just in the area where you are, or are you actually like people from all over the country, or what is if somebody's listening to you from Utah, can they go to your website and sign up, or how does that work?
Yeah, where we're at right now is we're on a fast track right now. We're about almost 6 months into we've already laid out the paperwork to get the medically licensed in all 50 states. Currently right now, I think we're about 3 months away from being licensed in all 50, but it's also one of those, we are licensed in almost 20 of the states right now. So again, the faster the state's medical board can, the faster they move, the sooner we can join in. But it's one of those, if anyone's that's interested in the program would be willing to go to our website, RecoveryPlus.health, and we can, based on where they live. The good part is geographically, we can see patients from absolutely anywhere. And so whether a patient's in Texas, New York, Florida, California, anywhere in between, hello, Alaska, if there's anyone out there, it does not does not matter if where you live, we're able to provide the same services regardless of where you live. So that's one of those things
Wow.
that we can.
Wow. That's great. That really is. I'm
Yeah,
just,
true virtual
yeah,
virtual medicine model. So like I said,
yeah.
we're bringing it back into the patient's home.
Yeah, no, I think that's great. Having seen, what my parents went through. My mom, that's one of the reasons I brought up osteoporosis, because my mom had very bad osteoporosis, but hers were all in her ribs.
Oh, wow.
Yeah, so it was, and back, it was difficult. But and my dad had Parkinson's, which a lot of the same, the need for help.
Right.
And my mother used to drag him to the hospital, get to do his exercises and stuff, and go to,
Yeah, I
yeah,
understand. That's a very familiar story. So no,
yeah,
I'm glad that was able to happen.
yeah, no, exactly. And that was many decades ago, many decades ago. So anyways, the both of them are long past. Off to a better place.
Off to a better place. Yes, ma'am. Yes, ma'am.
Anyway, so I just wanted to thank you for coming on. This has been even with our little break in the middle, not quite in the middle, but it's so great to hear of people that are taking advantage of the things that are out there to help people. I'm not being very good about saying this, but anyways, I'm very impressed. I'm very impressed that
Well, thank you. Thank you very much. It's been a pleasure to get to meet you, and hopefully we'll be able to provide, hopefully I was able to provide some good information to your listeners.
Oh,
And
yeah.
no, this was, like I said, thank you very much for having me on and having this conversation.
Yeah, no, thank you. And I will for sure put your the link to your website in the show notes for
Perfect.
everyone if they
Perfect. Thank
don't
you.
get it if they haven't gotten it in the in the podcast. So okay, well, with that, I will say that neither of us are medical professionals, and if you need some medical advice, please go to your doctor or go to the hospital for help.
Yes.
And with that, I will say thank you to Tim, and I will see all the rest of you next week.
Thank you.